Hello, everybody who's joining our webinar, and welcome to Dana-Farber's Department of Data Science Frontiers in Biostatistics webinar. My name is Erica Fike, and I'm the program manager for the department. If you have a question for the speaker or the organizers, you can use the Q&A tab in the webinar to ask your question. Our faculty organizers will manage the Q&A during and after the talk. So with that, I will turn it over to Svetlana for the introduction of Dr. Regan.
Okay, thank you very much. Thank you all for joining. Today is a great pleasure to have Dr. Regan give us a talk. She's an associate professor of medicine at Harvard Medical School. She earned her doctorate in biostatistics from Harvard School of Public Health. And she joined the faculty at Beth Israel Deaconess Medical Center in 2003. And then she joined the Dana-Farber Cancer Institute, our department. So her research focuses on clinical and translational research in breast cancer and also in GU cancers. In GU cancer, she's a part of the ICels group, which studies the intermediate and surrogate endpoints for overall survival in randomized clinical trials. She's a director of the International Breast Cancer Study Group. She's a director of the STAT Center, and she leads the trials and as well as the translational research work that is going on in the breast cancer, including large phase 3 clinical trials. Today, she will tell us about the treatment-free survival as a novel outcome measure for immuno-oncology-based therapies. We're very excited to have you, and thank you so much. Please.
Thank you very much, and thank you for that nice introduction. It's a pleasure to be here and talking with members of the department and outside of the department. So after that nice introduction, so I'm going to talk about a slightly different topic than a lot of my usual research, but I've been thinking a lot about endpoints over the last couple of years in various ways, and that's what I want to share a story with you today. And so here are my disclosures. So in phase 3 clinical trials in oncology, and in particular in advanced disease, overall survival is classically considered as the gold standard endpoint. And as therapies have evolved from cytotoxic to targeted and immune-based, there's been renewed interest and renewed focus on tailoring endpoints to the setting. We've been doing this by validating intermediate endpoints as valid surrogate endpoints for overall survival and proposing novel alternative efficacy endpoints. Also, we've been looking at the summary measures estimated from these endpoints, so they've received renewed attention with greater emphasis on clinical interpretation and clinically meaningful treatment effects upon the endpoints. And with success in extending the survival and availability of multiple treatment options in many cancers, this has allowed increased attention on the balance of efficacy and toxicity and the integration of efficacy and toxicity endpoints. This for just a minute. Sorry, I've got a little window in my way. That's kind of annoying. Okay, there we go. So, this is one of the issues. So you all know Kaplan-Meier curves, ubiquitous in analyses of time to event endpoints in oncology. And when we report these, we often report the median, which captures a shift in the distribution, reflecting a meaningful change for the majority of the population. Whereas we sometimes also report a milestone time point estimate, which may better capture durable benefit for a subset of the population. But of course, as we're always discussing with our colleagues, these measures reflect one moment across time. And so another measure that has been receiving renewed attention is restricted mean survival time. So it was funny, a colleague said, there's this new measure. And I was like, no, this has been around for decades. This is renewed attention on this measure. But the restricted mean survival time is generally estimated as area under a Kaplan-Meier curve. And then you do this up until a selected time t, here in the figure shown as 36 months. And so this illustration includes 3 treatment groups, which can be compared based on differences of the means represented as areas between the overall survival curves in this illustration, or can be compared based on ratios of means. And in the example, on average, patients assigned to treatment with IBI in green survived 21.2 months of the 36-month period since randomization. And those assigned treatment with Nivo in blue survived 24.9 months on average, which was 3.7 months longer than the IBI group. And our colleague, co-host, Hajime Uno, is one of the people who's been doing a lot of work in thinking about this measure. So restricted mean survival time, interestingly, I've found has also been used to revisit the approach of estimating endpoints, including one of our classics, duration of response. And so duration of response, we typically would define as the time from the first documentation of objective response until progression or death. But it's defined, of course, in the subset of patients who experienced objective response. But this itself is a random variable. So Huang et al. Have proposed to estimate duration of response as a population measure for the entire population. And so this is done as area between the Kaplan-Meier curves for two time to event endpoints. One is time to progression or death, which is our old friend progression-free survival. And you see it here in panel B. So this is data that they used as an example from an ALK-positive patient population in lung cancer. So PFS, there's the mean PFS in one of the treatment groups in panel B. And then the other endpoint they define is time until response or progression or death, which they show in panel C, so that you can look then at the difference in the difference in those in panel D to estimate the mean duration of response in the entire trial population. So this idea that they've done harkens back to a method called Q-twist, which was developed by Rich Gelber in our department and colleagues of his in that International Breast Cancer Study Group that I work with. And so Q-twist is quality adjusted time without symptoms and toxicity. This approach was first proposed around 1990 and is based on a series of restricted mean survival time estimates within a treatment group. So Q-twist is the idea to partition patients' life experience over fixed periods into regions that differ with respect to survival, disease control, toxicity of treatment. And it was developed in the context of the first use of postoperative systemic treatment, chemotherapy, in early breast cancer beyond their surgery. And in the setting, there was improved disease-free survival, so a measure of disease control, but we'd not yet shown there was improved overall survival in the setting. And so the idea was that this Q-twist approach would provide a balance of the benefit of remaining alive and disease-free versus the cost of experiencing treatment side effects of the systemic therapy, providing a therapeutic index for patient care. So I'm showing you here a figure from one of the early publications. You see this high-tech figure from 1991. It illustrates two treatment groups from a breast cancer clinical trial where there was 1 or 6 cycles of therapy for lymph node positive early breast cancer. And then the table is summarizing the 60-month, or they report as 5-year mean times for the endpoints and for the health states, which are they refer to for the areas between the curves. And so they report these for each treatment group, and then the difference they've reported, and they have bootstrapped 95% confidence intervals. So you see small differences in overall survival, larger differences in then the health state called REL or relapse after disease-free survival until death. But it's this twist period that's the focus that they saw a mean 2.4 month difference in the 60-month mean twist for using 6 versus 1 cycle of systemic therapy. So what happened is a couple of years ago, my colleague David McDermott at Beth Israel Deaconess described to me the situation that was evolving in advanced melanoma, where single agent and combination immune checkpoint inhibitors have contributed to an improvement in overall survival from a median of only 6 to 9 months to now recently reported more than 5 years with combination immune checkpoint inhibitors. In this setting, his concern was that classical endpoints, progression-free survival and overall survival, which have guided regulatory approvals and the clinical decisions for immune checkpoint inhibitors, that they may not provide a comprehensive assessment of the unique patterns of anti-tumor response that happen with these agents. And in particular, features are that patients who discontinue therapy may experience periods of disease control without initiating subsequent therapy. But on the other hand, they may experience ongoing or late side effects of treatments that persist after treatment cessation. And so he posed the question to me, how do we develop an endpoint, which has led us to propose treatment-free survival to try to simultaneously characterize anti-tumor activity and toxicity with focus on this period after cessation of an immune checkpoint inhibitor or immuno-oncology protocol therapy until the initiation of need for initiation of subsequent therapy or death. So our efforts began with one trial in which such patterns were observed, and that's CheckMate 067. It's a randomized double-blind phase 3 trial comparing nivolumab alone or in combination with ipilimumab or ipi alone. And this is patients with advanced melanoma that's previously untreated. And the combination arm shown in orange was an induction of nivo-ipi combination for 4 doses, followed by a nivo maintenance, as compared with the monotherapies, and they each had a matched placebo. And you should note that all treatments were continued until progression or intolerance. So what happened is that in 2015, the first results of the trial demonstrated prolonged progression-free survival and improved objective response rate of the 2 nivo-containing regimens versus ipi alone, and this led to FDA approval of nivo plus ipi. Now, as a note, PFS was also significantly longer for the nivo-ipi combination versus nivo, but this is a regulatory trial, so this was a descriptive, not a primary analysis, according to all of their protocol and statistical analysis plan. So what happened is clinical practice took up nivo plus ipi in combination. Now, in 2017, which are the results that I'm showing you here in the figure, this is when the mature overall survival results were presented because PFS and OS were co-primary endpoints. And the trial demonstrated an improved overall survival of both of the nivo containing regimens as compared with ipi alone. But as you see in the figures, the PFS difference seems to have attenuated a little bit. And the overall survival difference between nivo alone and nivo was considered to be, although again, not a primary comparison, was considered to be rather modest because this is in balance with the fact that nivo plus ipi has greater toxicity. In the trials, 59% of the nivo patients treated with nivo plus ipi had grade 3 to 4 treatment-related AEs, as compared to 21% and 28% of the monotherapy groups. And so clinical practice shifted to using the nivolumab alone. One other point I'll note is that in this trial, about 40% of patients stopped the nivo-ipi combination for adverse events. A lot of them during that first 4-dose period where the protocol said if you stop the ipi, you have to stop the entire nivo-ipi together and you can't do the maintenance. So after the first report, somebody else reported on a pooled analysis, which was CheckMate 067 with 069 trial, which was a similar design. And they showed in the subset of patients who discontinued the nivo-ipi early because of AEs during that combined induction period, that many of them achieved meaningful treatment-free interval. So in the swimmers, that's the yellow part of the lanes. And so this was, again, focused on 96 patients, a selected subset of the population who discontinued during that induction phase. And so you see the short treatment periods are those shown in blue here. And at the time they did the analysis, about 1/3 of patients who had discontinued had started subsequent systemic anti-cancer therapy shown with, and this was after a median duration of 25 months. So I've been critical of this work just a little bit in that this and similar analyses that we're often seeing in swimmer plots tend to report on selected subset of patients with than only presenting a partial picture of patients' experiences. And usually it highlights those who did really well. And the problem is for clinical application that physicians, when they're sitting with the patient, making the decision to initiate therapy, they don't know whether the patient will in the future become one of this selected subset. So while this durable anti-tumor activity seen after discontinuation of nivo plus ipi is very encouraging, there's also this issue of associated persistent and late onset treatment-related events that have been seen, and again, aren't visualized so far in that figure. So we wanted to then move forward as these combination of immuno-oncology therapies are increasingly applied to enhance efficacy. We wanted to improve the outcome measures and analyses to more comprehensively put together that efficacy and the toxicity. And so as a first step, we took a new look at swimmers plots. And so this is work done with Lillian Warner, who you'll remember from our department. So one of the first things that we did with the data is to take a different look, and this is the CheckMate 067 plus 069 in what we called enhanced swimmers plots. So they plan to be more comprehensive, but also we wanted to focus on this treatment-free interval period. So I'm just showing you here a random subset of 100 patients who were randomized to the nivo plus ipi arm, just to give you better visualization today as we talk. And so you see that we reoriented the x-axis with time 0 is the discontinuation of the immuno-oncology protocol therapy here, with bright blue being the treatment-free interval after IO therapy discontinuation, and we truncated out to 30 months. And the gray to the right shows you this initiation and survival after subsequent therapy, subsequent systemic anti-cancer therapy was initiated, with the deaths indicated by the red dots, which may be at the end of the treatment-free interval or after subsequent therapy. Now to the left, you see in purple the prior protocol treatment, showing those with brief treatment, like in the earlier swimmers at the top, but also many with longer treatment, and of course, some still on therapy. And you see that axis is truncated at 24 months. They were still on it, which reflects also disease control on treatment. And that's a good thing that had also been ignored in some of the prior looks at the data. So now, if we look at that together with all three treatment groups, different patterns start to emerge with respect to their survival, treatment administration, and the treatment-free intervals. So we thought that this was an improvement over the previous swimmers plots because we can get all patients into this analysis and we could get more details of the actual treatment experience of patients. But of course, swimmers plots are not to provide summary measures for inference or for the population of the treatment groups. And so we've proposed then that treatment-free survival as an outcome measure should simultaneously characterize that anti-tumor activity of treatment-free interval, the toxicity, and also this period of cessation, the treatment-free period until subsequent therapy or death. And what I did was to take the inspiration of Q-twist, the idea of partitioning patients' experiences over a fixed period of time into regions that differ with respect to survival, treatment administration, and toxicity. And to do that, there's a couple of things that I wanted to emphasize, which is that we wanted all patients, not just a subset of patients. And that's one of the reasons why I like this approach. But again, coming back to this late toxicity so that we're balancing the good of the durability of disease control with the potential downside of late toxicity of initial therapy. So this is how we do it. Here we start with Kaplan-Meier estimate of overall survival of all randomized patients in one of the treatment groups. So we add another time to event endpoint, time to protocol therapy cessation. You'll note that in this illustration, some patients continue on therapy at 36 months, just under 20%. And then we add a Kaplan-Meier curve for time from randomization until initiation of subsequent systemic therapy or death, sometimes called time to treatment failure, or time to second line treatment. And so then we use restricted mean survival time and estimate the 36-month mean time on protocol therapy here. And then this area between the Kaplan-Meier curves for protocol therapy cessation and subsequent therapy initiation is treatment-free survival. So we introduced this other endpoint. That's not really a time to event endpoint, to capture cessation of both the therapy and to capture any residual toxicity after therapy. And this then allowed us to partition TFS into periods of time to represent it as times with and without toxicity. And then finally, this area up here, we refer to as survival after subsequent therapy initiation. And we also, in plotting these figures, also show the period of death, which is mean survival time lost over the 36-month period, which of course is ultimately what we're working to minimize. So I'm going to show you now the analyses that we've done with CheckMate 067 in this other CheckMate 069 trial that had the same design. And our fixed time period is going to be 36 months since randomization. And we're going to go through the analyses I've just described. And so for toxicity, I'm going to show you two alternative definitions that we've used with this trial. One is based on grade 3 or higher treatment-related adverse events. But then we also looked a little bit more broadly as grade 2 or higher treatment-related adverse events. And so like the Q-twist method, what we do then is to count the unique number of days with one or more treatment-related AEs. And again, for the treatment-free survival period, they could have either started and been persisting from the protocol therapy period, or they could be newly reported after discontinuation of therapy. So here are the pooled overall survival results of the two trials, in which overall survival was improved with the nivo alone or nivo plus ipi combination as compared with ipi alone. And although not a trial objective, very relevant clinical question is whether there are any benefits to the combination of the nivo ipi as compared with the nivo monotherapy. And so here we split the overall survival curves into separate plots. And then we see again, 3 different patterns of patient experience on the 3 immuno-oncology regimens. So at the left, the mean treatment-free survival with nivo plus ipi was 11.1 months. They're highlighted in blue area. So patients were treatment-free on average about 1/3 of the 36-month period. And this resulted from a lot of early discontinuation of protocol therapy in the purple area. And then TFS with nivo plus ipi was about 2 times longer than for nivo alone, which was 4.6 months on average, shown in the middle figure where you see nivo was given for a longer duration. And then at the right is the ipi group with its fixed 4-dose therapy. So I'm not showing the placebo, obviously. And this shows actually substantial treatment-free survival for this group because of the short duration therapy. It's a mean of 8.7 months, but also you see the earlier initiation of subsequent therapy and the poor overall survival here. And so when treatment-free survival was partitioned to represent periods with and without toxicity, the 36-month mean TFS with grade 3 or higher treatment-related AEs, which is that shaded blue area, this was a small proportion of the 36-month period for all 3 of the treatment groups. And then when we look at the broader definition of toxicity, you can see that the 36-month mean TFS with grade 2 or higher treatment-related AEs, again in shaded blue, was greatest for the nivo plus ipi combination. But the TFS without grade 2 in the solid blue is still remaining about 2 times longer than for the nivo monotherapy group in the middle. In CheckMate 067, there has been sustained long-term overall survival benefit. Here shown over a 60-month follow-up period of both nivo-containing regimens versus ipi alone. And so the question arises, is this prolonged survival accompanied by sustained treatment-free survival benefit of nivo plus ipi versus nivo and ipi monotherapies? And so the answer is yes. So on average, patients treated with nivo plus ipi have been treatment-free for about 1/3 of the 5-year, 60-month period since they initiated that therapy. And so the blue area represents a mean of 19.7 months, the 60-month period. And this again is about still twice as long as for patients treated with nivo monotherapy. And you see also that the ipi monotherapy still maintains a longer average treatment-free survival than the nivo group in the middle, although again, the poorer overall survival. So one of the things that we did in thinking about the follow-up data is to think about what it means in terms of our first estimation at 36 months as compared with longer follow-up at 60 months. And so you see here, some of my colleagues don't like looking at the Kaplan-Meier curves. I like those illustrations. And so we've jammed all that time from the Kaplan-Meier curve into these stacked bar plots. And so you see that in comparison with the initial TFS estimate after 36 months, the mean TFS at 60 months is now a slightly greater percentage of the follow-up period for both of the nivo containing regimens. So the means are now 33% and 17% of the follow-up periods. Whereas for the IPI group, the mean TFS is now representing a smaller proportion. It's about 20% of the 60-month period since randomization. And so this gave us some insight of the maintenance and the persistence of disease control with the mean is always going to get larger, but does the mean get larger as a proportion of time? Whereas we see the pattern going the other direction in the IBI group that had the inferior efficacy. And so I've also found, I guess the other thing I would note here is that I found that communicating restricted mean survival time with colleagues, it's worked well. Actually, to often re-express this mean as a proportion of the follow-up time, that's something that has resonated with them in getting them to stop thinking about the median, which is what they're all used to always seeing. And so one of the other things that we had done in thinking about the longer term follow-up is that we had previously recommended in our first discussions of TFS that TFS should be analyzed in future clinical trials involving immune checkpoint inhibitors. And so once we had this longer follow-up, we went back and re-estimated treatment-free survival in the other survival states by sequentially restricting the follow-up time from 24 to 36, 48, and 60 months since randomization, with the idea that this would imitate the maturing of a clinical trial results with accumulating follow-up time. Wanted to get an insight of, when should we estimate treatment-free survival? What might our data look like? How it might interpretation differ depending upon when we do this. And so the way that I thought through this was to focus on the magnitude of the between group differences in TFS that might be observed in the three treatments and their relation to overall survival differences with the longer follow-up duration. And so in the first panel A, we're focusing on the between group differences in the mean overall survival of nivo plus ipi versus nivo, which is the black line there. You see the modest increases in difference with longer follow-up that's been observed. And then you see the estimates of the between group difference in mean TFS in blue. And you see that those have increased more substantially as follow-up duration has increased. So in this setting, treatment-free survival has provided us a little more insight than overall survival. On the other hand, when we look over at B for nivo-ipi versus ipi alone, we see again, just focusing on the black and blue lines again, that the increase in the magnitude of the difference between an overall survival, we see that as that has increased, the difference in treatment-free survival in this setting has also increased in parallel along the way, although lagging behind at the very first point of 24-month follow-up. So this was some recent work. Again, these are restricted mean survival time curves that have traditionally been used thinking about what do I do for a restriction time point that you have to select with restricted mean survival time, and trying to think about how that affects your inference. And so we had used it a little bit more here to think about what might TFS look like as we apply, if we applied it prospectively in a new randomized trial. So far with in advanced melanoma in these trials, we had been focusing on a trial where we had 3 different immuno-oncology regimens. And so we next turned our focus to the CheckMate 214 randomized phase 3 trial, which reported significantly longer overall survival with nivo plus ipi versus sunitinib in patients with advanced renal cell carcinoma. And so those results are shown here. And this provided us an opportunity to explore TFS in a comparison with a different solid tumor than melanoma. It also provided us an opportunity to look at an IO regimen versus a systemic therapy or a targeted systemic therapy, so a different mechanism of action. And then what happened here is, I'll explain a little bit more, the regimen is slightly different, and so there was less discontinuation for treatment-related AEs. In the kidney cancer trial, it was 20% of patients, whereas it had been about 40% in the melanoma trials we'd already looked at. And so this gave us another opportunity to think about this endpoint, and this is work that I've been doing with Yemi in our department. And so in the open label CheckMate 214 trial, it's patients with treatment-naive advanced renal cell carcinoma who were randomized to either nivo plus ipi, again given in combination 4 doses, then a nivo maintenance with a slightly different induction dosing of the nivo ipi to be more tolerable. And that was compared to the VEGF receptor tyrosine kinase inhibitor sunitinib, which was the standard of care treatment in this patient population. And again, you should note that the treatments were given until disease progression or intolerance when the protocol was first written. It's just over 1,000 patients. And in RCC, there's a standard prognostic score, IMDC, which Wan Ling was instrumental in developing in our department. That is the standard for thinking about intermediate and poor risk versus a more favorable or risk patient population. And so this population is 77% intermediate poor risk, which is about what you would see in advanced renal cell carcinoma. And so that is the primary trial population. And then a favorable risk population is more exploratory. And so for our analysis, the minimum follow-up is 42 months, and that's been our time point of focus. And so here you see, again, these enhanced swimmer plots that we've been doing that show different patterns of survival, treatment administration, and treatment-free intervals between the nivo, ipi, and sunitinib treatment groups. And so here, everybody is here, all 500 or so patients per treatment group are jammed in there. And with the experiences of the smaller subgroup with favorable risk disease at the top of the figure. Now, one other modification we've made to the approach as we've continued to develop this approach is to also now represent the time on protocol therapy with and without toxicity. So we thought that this was particularly relevant in this RCC comparison, where we have an IO combination versus a targeted therapy. And so here then are the results. And so this is focused first on the primary population of intermediate poor risk disease, where overall survival was superior with nivo ipi as compared to sunitinib. Here you see that the mean treatment-free survival in the blue areas was more than twice as long was 2 times longer for the nivo ipi versus the sunitinib treated patients. So it's 6.9 versus 3.1 months over the 42-month period since randomization. And again, the treatment-free survival with grade 3 or higher treatment-related AEs in both treatment groups was a small proportion of TFS overall. And so the lighter blue areas you can barely see in these figures. So I think a little bit more interesting to be able to see those with grade 2 or higher treatment-related AEs, so the little broader definition. You see that TFS with grade 2 or higher treatment-related AEs is greater after nivo plus ipi in the lighter blue here. Yet the treatment-free survival without grade 2 or higher treatment-related AEs in the darker blue still remains about 2 times longer, so 3.9 versus 1.5 months for the nivo ipi versus sunitinib groups. You can also see the mean time on protocol Nivo plus IPI with grade 2 or higher treatment-related AEs was actually just slightly shorter than the sunitinib group, 5.7 versus 6.4 months, depicted by the lighter purple areas here. So we had just in illustrating had chosen to put the two periods with toxicity adjacent to one another, just as an illustration. And then you can see that the two light areas of toxicity on treatment or after are pretty similar, just slightly longer with the Nivo plus IPI. So this turned out to be a really interesting part of the analysis because the intermediate poor risk had been the main focus of the analysis and of the approval of this therapy. Within this favorable risk population, where the overall survival you can see is very similar in the two treatment groups, here we observed a greater between group difference in TFS in comparing Nivo plus IPI versus sunitinib. Here, treatment-free survival was 3 times longer for Nivo IPI as compared to sunitinib patients over the 42-month period, so 10.1 versus 3.4 months. And this is again depicted by the darker blue areas, and you're seeing also the smaller areas of the grade 3 or higher treatment-related AEs in both treatment groups again. Let me also overlay grade 2 or higher treatment-related AEs here. So the mean TFS without grade 2 or higher treatment-related AEs in the darker blue areas remains 3 times longer for Nivo IPI than sunitinib patients, so 6.9 versus 2.3 months. And then you can see in the sunitinib group, which again has been the standard of care, that the patients assigned sunitinib spent approximately half of the 42-month period on protocol therapy, and most of this with grade 2 or higher treatment-related AEs. And so this is the lighter purple area, which is 13.7 months on average with toxicity of a mean 20.2 month treatment time on protocol treatment. So as we've brought these results together, our colleagues have been incredibly interested in clinical interpretation and thinking about what they've learned from these regimens as opposed to the typical presentation of progression-free survival and overall survival. And on the other hand, while I'm happy to be able to contribute to that, I think also been thinking about this continued development and how we think about TFS in these and future trials. So, one of the main intentions in developing this TFS, which is clearly a work in progress, I wanted to be sure that we were including the experiences of all patients from randomization, which in these two trials has been initiation of first systemic therapy for cancer. And I had the opportunity to present this work in the kidney cancer at the Kidney Cancer Symposium. And the patient advocates who were attending during and after and talking with them were very responsive to this and being able to think about, love the idea that you can think about that they're surviving longer and the quality of how they're spending that survival time. So it's important to remember though, and I emphasize this with my clinical colleagues, is that the estimates that we're seeing and reporting to date, they're all constrained by how the protocols were written and how they specified treatment being used until disease progression or intolerance. So we do not know whether treatment could have been stopped earlier in other patients with Nivo IPI or Nivo alone, for example, in the melanoma trial, or whether that could have happened and thereby extended their treatment-free survival without compromising their overall survival. We just don't know because we're retrospectively applying this to data within the context of the trial. One of the things that we're trying to, next step that we're trying to think about is that our approach assumes the quality of life varies while on and off anti-cancer therapy and with and without toxicity, but we've not been able to show this directly. So we'd like to bring in, there are quality of life measures from this trial. They don't often, though, quality of life measures stop when treatment stops, or they might get one follow-up, so we don't necessarily have continued data throughout the treatment-free period, which is a little bit of a drawback. But we're hoping to be able to take that and to use the idea that Q-TWIST was a quality adjusted, so it was a utility weighted approach. So hoping that we'll be able to bring that in to account for differential quality of life during the health states. One of the other things that we're working on is this idea of toxicity and how we define toxicity definition. I think with the approach, one is able to define toxicity however you want, but it's number of days with one or more toxicities. It'd be very nice to be able to bring in more about the intensity of treatment, the intensity of the toxicity, the number of toxicities they're experiencing. I mean, it's definitely, we have a lot of discussions that right now in the approach, if the patient has a grade 3 colitis or a grade 2 laboratory abnormality, and they're both treatment related, they're being counted exactly the same, and that's very unsatisfying. So we're hoping that some of the new approaches in thinking about trying to better weight toxicities might be able to be implemented here. And then finally, we have another collaboration ongoing with colleagues at FDA, where they have, we want to look at, there's a bunch of new trials in kidney cancer where there are combinations of an immune checkpoint inhibitor with the targeted therapy as compared to the targeted therapy alone. And so we want to look at what treatment-free survival looks like in that kind of combination therapy. So just want to wrap up with the last couple of comments. So, these analyses of the CheckMate trials, I think, demonstrate the value of describing the quality of the overall survival time in assessing IO regimens. So here specifically immune checkpoint inhibitor regimens that are being developed. And specifically, I think they provide some insight that may help guide treatment choices when considering initiation of first-line IO-based therapy in patients with advanced melanoma or RCC. I think they provide a new insight to the data that were already available. I think they could provide new insight to the experience of regimens, as I mentioned, that were recently reported in clinical trials of other combinations, and especially those IO targeted therapy combinations. And we're trying to encourage colleagues to take this approach, to take a different look. But I think what's most interesting and exciting is the idea of bringing in treatment-free survival prospectively into the design of future clinical trials as a complementary endpoint. Obviously not ready at all to be a primary endpoint in a trial, but especially as trials look to develop regimens that are refining treatment approaches or trying to think about increasing treatment-free survival without toxicity, and trying to tailor therapy and reduce therapy where it's possible. And so, what we hope with this approach, right, is that you'd like to be able to contrast regimens that we hope will increase TFS by decreasing toxicity of therapy and decreasing treatment time while maintaining and perhaps even improving overall survival. This would be fantastic for patients if we could, in development of regimens in this way. And I'd like to be able to show this picture for some regimen in the future. But I'd also then think it's important to be able to contrast that with some of the combination regimens that are being developed, which are continuing to improve survival, but maybe doing so by increasing treatment duration and the toxicity of the treatment. And so our goal with TFS and trying to put it together in this integrated analysis approach motivated by Q-Twist is to help really improve our assessment and contrasting new treatment regimens and help with their implementation in clinical practice. So I'm going to stop there, but I have to acknowledge David McDermott, my colleague at Beth Deaconess, who came to this and said, how do we develop an endpoint? Which got me all excited. Mike Atkins, who used to previously be here at Beth Israel Deaconess, is at Georgetown, who's very active with ECOG Akron and some of our colleagues, Lillian and Yemi in our department, who've been very active with me with this work and get a lot of the credit as well as Dr. Mantia, who's an early career faculty member now at Dana-Farber, and colleagues from outside, colleagues at Bristol Myers Squibb. We've been working with their health economics and outcomes research team, and it's been a very nice collaboration. And I have to give a huge shout out to Jane Hayward, who has been at Beth Israel Deaconess Creative Services, because I did not make those those Kaplan-Meier plots. That's the outstanding animation that she and some others have assisted us with. And importantly, that this work is also supported by the Kidney Cancer Spore. So thanks very much. I'm going to end there.
Thank you very much. That was very interesting. So if anybody has questions, please send them to the Q&A sessions, and then I will read them to Meredith. And I wanted to ask, so it looks like this should be applicable, like not just to immunotherapies, right? That could be any type of treatment with any type of toxicities. So it's like, does it matter whether it's kind of like this long-term and delayed toxicities, or it's applicable to any like targeted treatments and everything?
Yeah, it would be applicable to any treatment. And, you know, we emphasized for immunotherapy because one of the issues is that those toxicities can really persist. And a lot of other therapies, once you stop treatment, the toxicity comes back, or reduces and goes away fairly quickly, where some of the immunotherapy toxicities have persisted. And that was a lot of discussion in the community, was about these persistent toxicities and what that trade-off was about. And so that was one of the reasons why we emphasized it there specifically. But no, certainly you could look at it with any treatment approach. It has been looked at also actually I found later that somebody else took a similar approach in a hematologic malignancy, actually had taken it. And I think the idea of, I mean, as you saw with the work of others, and that the idea of putting together the multiple survival curves and partitioning overall survival time could really be any kind of time to event endpoints. You know, we see often like PFS1 and PFS2 is sometimes we're starting to see in other in clinical trials. I think you could do that. So I think it's it's definitely a more broad approach that could be tailored to the setting, as long as you have people moving from one place to the other. Yep.
Well, yeah, I was actually thinking exactly about hematologic malignancies, because as far as I understand, their kind of frontline drugs have like severe cardiotoxicities, and right now they're developing the newer generation ones. So that seems to be sort of a interesting approach to actually even compare the generations of drugs that are, the goal is to reduce toxicities, and then maybe that they don't really improve the survival too much. It's not a very big deal if they significantly help with the toxicities. Yeah.
Right. And patients living a better quality of life during their lifetime. Yes, absolutely. Yep.
So we have the question from the audience. Zhang Wei is asking, does TFS handle combined treatment-free sections? For example, after randomization, one arm of patients will wait until prognostic signal and then start treatment. Patients then receive a fixed period of treatment. The next line therapy will start at progressive disease. So there are pre-treatment TFS and post-treatment TFS, and we want to compare the total TFS to another arm which starts treatment right away.
Interesting, very interesting question. I think that it would be possible. I think we'd have to sit down and think about it and how you're defining that series of time to event endpoints and how differences in them could give you the specific period that you wanted to estimate. But, and I mean, one of the things is that they don't strictly have to be time to event endpoints. I mean, like in the original Q-twist, that tox period isn't really a time to event endpoint in a strict speaking. Sometimes we just, in the toxicity parts, you just count all the individual days and then you glom them together into one contiguous number of days. They didn't actually happen that way. So I think that you could think through it. It's really an interesting way to think about how to put that together. So I think it's possible. Happy to talk about it. Cool idea.
Yeah. Meredith, thank you very much for a very much fantastic talk. I very much appreciate. So I have one question. So in your analysis, so you're gonna, separate the survival curve into several areas, right? So now you have the several areas between two groups. Maybe some area treatment group is good, better than the control. And for some area, control group might be better than the treatment. So in that case, how we determine which treatment is good? I mean, better. So is there any way to integrate and then create like a global summary measure using those areas?
Yeah, great question. So when you go back to the original Q-twist, so they do a utility weighting to try to bring together some summary measures. So we haven't focused on that approach of trying to have one global summary measure, but I think that you could attach utility weights depending upon the specific setting of what was more and less important to be able to bring together more of a global summary measure, especially in the setting where overall survival was very similar. And so you weren't competing with overall survival and you were really thinking about how the time was spent. I think it would be possible with that kind of approach to utility weighting. But we haven't really thought about that because I kind of ignore and barely talk about the gray area of survival after subsequent therapy. It hasn't been so much of interest to us, always displaying, but I think possible.
Thank you, Rich.
Thank you so much again. It was very interesting and enlightening. And so, yeah, we will all think now how we can apply it to our own things that we study.
Thank you. Thank you for the invitation. I really appreciate it. So I'm very happy. I mean, Jahan's question was very interesting of the creative ways to rethink about this and looking at data. So yeah, endlessly fun. Thank you. Thanks all for coming.
Thank you. Have a great day.
Bye.